Good morning. I'm Amitay, VP Engineering at Brook, and Julio, Bonis, MD and Data Science from Pacific AI will present together with me. Today we'll show how responsible LLM let us scale personalized chronic care safely. So let's start by seeing how big the problem actually is. So chronic care demand is exploding, and the current system can't keep up. 80% of the age of 65 plus has at least one chronic condition. The medical spend focus mostly on chronic conditions, and you can see that the shortage of nurses and physicians is just going and going. So if care can't be continuously present, how do we make it ever present and safe? That's exactly what we are building toward. So today we'll discuss the challenges, our architecture, how we keep human in the loop, and how governance make it scalable. First, who is Brook and what do we actually do? Brook delivers zero-hassle remote care. Devices with AI, with a human care team that operates as an extension of the provider. So how we can deliver 24/7 health awareness? We're doing it through devices and data, integrate with provider system, the EMR, all this feeding our AI with a lot of context to deliver personalized care plan and adherence nudge and improve patient engagement. And all this with our care team in the loop to guide our patients through treatment plan and provide support. We don't replace the primary care providers, we extend them. So what does that look like in practice for patient? So here is a very simple patient story that showed the difference. Joe, 67 years old with CHF, wake up in the morning, getting a nudge to take a blood pressure reading. He's using this device, taking blood pressure reading, and the reading is okay. He discussed with the AI companion, ask few questions and get some recommendation for the day and continue his day. A day after, Joe wake up, get the same nudge, put the blood pressure cuff on his hand, taking a reading, and the reading is high. The system automatically asking him to take a second reading. He's taking a second reading, and it's still high. The system asking him few follow-up questions. He's reporting that he's dizzy, wake up with headache. The system automatically escalate this conversation from the AI to the nurse. So fast confirmation, timely human intervention, avoid escalation of the situation in this case, and in some cases, even avoid the ER visit. So Brook AI Companion run most routine interaction, and when things escalate, humans step in immediately. So if AI handle routine work, what do nurses do more of? So higher value clinical work is what the nurse will focus on. To make that reliable, we move to a multi-agent architecture. So why does it matter? Because healthcare tasks aren't all the same. Translating Spanish, detecting a CHF escalation, or coaching on behavior change, each of these has different risk and evaluation criteria. A single do-everything model is a black box. Multiple specialized agents mean separation of concerns. These separations give us auditability, governance. For example, we can test the translation agent for accuracy and bias with benchmark sets without it being mixed up with the risk scoring logic, for example. That's why if one piece drift or fail, we can isolate, monitor, and fix it without destabilize the entire system. It also gives us granularity in safety control. Each agent has its own policies, benchmark, and guardrails. We architect the system as a modular specialized agent, each one testable, auditable, and replaceable. That's how we keep the AI reliable at scale. But is this actually enough for AI system in healthcare? That questions take us to human oversight and escalation design. So as I just showed in the scenario earlier, finally human determination is a core requirement for critical decision. Humans are always in the escalation path. With human in the loop, the patient never feels the button drop. AI hands the case to the nurse with context, and the nurse picks it up right away. And to mitigate automation bias, transparency is the key. It is part of the UI design to give full transparency about the AI companion, and it is true for both the patient and the nursing side. That's why governance and security must start from day zero. So in healthcare, safety and compliance are not add-on. They must be embedded from day one. Advanced guardrails, compliance best practices, security architecture as a foundation, and design insurance, for us, it's enable faster innovation. So these principles are developed in healthcare, will be best practices in many industries, I believe. If we are not bake this in, what risk are we accepting for patients and providers? Which brings me to how we collaborate with our partners. I will now hand off to Julio from Pacific AI to go deeper into governance, policy suite, and test automation.
Thank you, Tal. I will be covering how we, from Pacific AI, we have tried to help Brook to achieve their goals in terms of safety and all the concept that Tal has introduced it. And the most important message here is that responsible AI is not only a technical challenge, but it's more like our organizational challenge. So in our approach, we cover 4 dimensions. The first one is governance. We need to deliver a policy that is customized to each use case and covers, all global AI laws and regulations. We need to provide with training that is customized to the different roles within the organization, from the general staff to the more technical people. We need to also provide with a way to audit that all these responsible AI measures are taken and are covered. And we have a platform to do that, but of course this can be done with any third vendor platform. And of course we also implement a platform for actually testing the system in a scalable way, as we will see. About the governance, all the governance is must start from the beginning. Even before writing the first line of code, you need to start to think about how you will apply responsible AI, and that can be done thanks to having a framework. And in Pacific AI, we have developed a policy suite that can be used and customized to each customer. And this is what you see. This is an example of the kind of document that we use to approach this governance first approach from the very beginning of the project. We cover in this policy 7 dimensions of pillars of trustworthy AI or responsible AI. First one is fairness. We need to make sure that the AI system treats all individuals equitably. We need accountability, meaning that all the responsibilities must be clearly defined. We need transparency. We need to make sure that AI decision-making processes are understandable and clear. We need reliability, meaning that the system must perform consistently under different conditions. We need, of course, safety, and in healthcare, this is a very important dimension. We also need to be sure that privacy and security is provided. And finally, we need also accessibility, because in most cases, and especially in healthcare, you have users that are disabled or have different health issues. So you need to make sure that the system is accessible for all them. About the design assurance is not a tool, it's more like a process. And its purpose is to systematically identify, analyze, and propose mitigation actions to potential risk before these risks appear. And so, meaning that this allows a proactive and not reactive safety approach. And of course, around the design assurance process, you have different deliverables or different artifacts. Those could be the design assurance document, where you register and you document all this process. You have a risk registry that is a dynamic registry where you include the different risks that you identified and the mitigation strategies, and is updated periodically. You have an impact analysis that is done at the beginning, involving all the stakeholders, not only the technical people, but the potential users, and is also reviewed every year. As we have mentioned, you have a training program. You have you need to design some guardrails that we will cover, and of course you need to deploy automated tests. Regarding guardrails, and to be and briefly to cover this idea, in this case, what we designed with help of Brook was two kinds of guardrails. The first guardrails are input guardrails that checks when the user is interacting with the tool. It will check if there are some clinical emergency that needs to be covered, or self-harm language, or any kind of adversarial prompts that is trying to harm the system. And then you have output guardrails that will check before any message or information is delivered to the patient. It will check that the system is behaving as it's expected. For instance, it's not prescribing any medication or medical advice, because the system is not designed for do that, or is not using biased language, and is safe, basically. And you see here in the bottom of the slide how the process is basically happening in the system. So the user input will be checked by the input guardrails. Then you have the internal functioning of the system, and before the patient receives any message, you establish an output checks. How does it work? How does this testing automation works in practice? We need to get all these design principles into practice. For doing that, we have a platform that is designed to automate this testing. One important characteristic of this platform is that it has a simple user interface for non-engineers. So people like compliance staff or clinical teams, they can also interact with the tool, run tests, and review the results. So it's not a technical thing. It's something that is accessible to anyone in the company. How does it work? We have built a kind of comprehensive benchmark suite that is composed by three main components or modules. On the left, you have the MedHelm, that is a kind of a standard these days, and it consists in a set of tests that will automatically detect inaccuracies and enhance clinical relevance. Then we have the lung test, that is a specific tool developed by us that will ensure fairness, robustness, and consistency, basically presenting the similar cases to the AI system, but changing demographics or changing the order of the symptoms. All these small changes that theoretically should not change the response of the system, and we can check that with the lung test. And then, of course, we have a specific red teaming to proactively detect safety and policy violations that I'm describing you in more detail here. So how this red teaming works? Red teaming is basically a platform with a set of adversarial test cases that are created by clinicians from scratch, where we describe a clinical scenario, and then a task that is requested to the system. Then we have we use LLM as a judge that we have checked that works similarly to human as a judge in our internal testing. And this LLM as a judge will basically check three types of things. The first one is general criteria testing. Here we give the LLM as a judge the trick, the nuances of the clinical case to be able, so the LLM is able to solve it, and it's based on a static rubric. So we specify to the LLM as a judge, you need to check that the response contains this or that in clinical terms. And of course, we have for each of these scenarios, we have a must-avoid testing list of things that the system must avoid, and must-do testing, where we describe things that the response must include in any case. For example, the response must always include a safety net plan or compassionate language or whatever. Once we have all this of these scenarios defined, and we have the LLM as a judge, we can test any system like the Brook AI system to see if it is behaving as expected, and we generate an aggregated report that can be consulted by anyone in the company. And now for conclusions, I let Tal to continue.
Thanks, Julio. So now let me close the loop with the universal blueprint we follow. So our blueprint is simple and repeatable. Together with the large effort of the core development of our AI systems, we embed governance, proactive safety, universal pattern, automation, and integration. Adopt policy suite, use design assurance to map risk, implement guardrails, human-in-the-loop patterns, and embed benchmark in pipeline is what let us continue innovate. If you do these four things, how different could outcomes be at scale? So safety, compliance, and innovations are not competing priorities for us. If you zoom out beyond healthcare, maybe not today, but in the future, you will see the same pattern everywhere. I truly believe that the AI product that succeed will be those designed with safety as a first principle. Thank you, Julio, and thanks everyone.